Hi everyone. Okay, so today I'm going to be going over the autonomic nervous system. I know there's been a lot of confusion on this system, but I think once you get it down, it'll help you with a lot of other classes of medications because as you'll see when you continue your studies, is that a lot of these drugs are going to repeat themselves. So understanding the drugs now is going to help you in the long run. So, without further ado, I'm going to talk about first the differences between the sympathetic and the parasympathetic systems. So, just briefly, you have two different responses in your body, one that helps you with fight or flight, and the other one that has rest and repair, which is your parasympathetic is your rest and repair, and your fight or flight is your sympathetic nervous system. You also have your enteric nervous system, which is for digestion, but we're not going to get too much into that now. My main focus is because I know that you have upcoming quizzes and I know this information is very hard. So I'm going to try to explain everything in a condensed manner that is hopefully going to make a lot of sense. Whether you're in Dr. Balkan's class or Dr. Kassler's, it doesn't really matter because the information you're still going to need for your NCLEX and the types of questions will be similar between the sections. So basically, in order to understand any class of drugs, the way I study is you need to know the receptors. You need to know where that drug works, because if you know where it works, you know what the drug does. It's simple as that. So before I get into that, we need to know the signs and symptoms or the things that you would expect to see in the sympathetic versus the parasympathetic system. So when you're working in the autonomic nervous system, you're talking about the sympathetic nervous system or your fight or flight. So some of these symptoms, which I highly recommend you writing down, are increased heart rate, increased blood pressure, gluconeogenesis, which means you're forming more glucose, so it's going to raise your glucose levels. Anytime your body undergoes stress, you expect your sugar levels to raise. Because remember, in fight or flight, you're talking about your body being like energized, right? So everything's being heightened. So your sugar is also going to increase. You're going to have pupil dilation, or mydriasis is another way of saying pupil, or your pupils dilating. You'll also have decreased GI motility, which means that you are not going to really be able to go to the bathroom or things like that. You're also not going to be able to pee. So all of your little GI functions are not going to work. And you're also going to have increased sweat because, like I said, this is a fight or flight. Now, when you think about this system, I want you to think about you're running from like a robber, right? If you're running from someone, you're not going to need to use the bathroom and you're not going to need to pee, but your heart rate is definitely going to go up. Your blood pressure is definitely going to go up. You're also going to have your sugar levels increase. Why? That is because, as I said, anytime your body's under stress, your sugar levels increase. So keep those symptoms in mind. For parasympathetic, it's the opposite. So your heart rate decreases, your blood pressure decreases. This is your resting phase, right? You also have increased GI motility. So you're going to go to the bathroom, you're going to pee. So those are some of the differences. And I want you to remember the term SLUD. SLUD stands for, well, let's spell it out. SLUDD. It's secretions, lacrimation, urination, defecation, and digestion. That is going to be, at least for me, it is the key for all parasympathetic working drugs. When you know SLUD, that tells you a lot about its adverse effects and also what it does. So if you know the acronym SLUD, you're going to know a lot. It's going to tell you a lot about that drug. One more thing that I wanted to point out that's different between sympathetic and parasympathetic is that with the sympathetic nervous system, you're going to have bronchospasms or constriction of the lungs, right? Sorry, wait. The parasympathetic system, I didn't know if I said, I just want to repeat that. The parasympathetic system or the cholinergic system causes bronchospasms because in the parasympathetic system, if you're going to be resting and digesting, you don't really need your lung capacity as much, right? Because when you eat food, that epiglottis covers your trachea so that you don't choke, right? So you're not breathing as much when you eat or when you rest. But if you're running from somebody, you need your lungs to be bigger because you need that exchange of the gases so that you can get away from that person. So think about with sympathetic, you have the opening of the lungs, and also in parasympathetic, you have the closing of the lungs. And another way of saying sympathetic nervous system is saying adrenergic, which is what the next class of drugs that we are going to be talking about works on. And the last thing that I want to mention before I get into the drugs is I highly, highly, highly recommend that you use a drug template. Now, you could search any drug template on the internet. You can find them in the back of your ATI books. You can find them on Notability. I love Notability, but I can also send you one if you need one. But regardless, I suggest using a drug template. And if I'm able to show you an example of a drug template, I'm just going to pull one up for you. So that's going to take a second. And I'm going to switch my shared screen to an example of a drug template just to give you an idea before I continue. Like I said, you can use any, you don't have to use this one, but if you're a typer or you like to type, you can type on it or you can print it out. Let's see, let me see if I could change my screen. I'm going to stop share for a second. I'm not the best when it comes to technology. I apologize, but okay, so this is a drug card or a drug template. This is an example. So I think it's useful because when you write out your drugs, there's a lot of information, and a drug is not just a drug. You don't study metoprolol. You don't study albuterol as one drug. You study it as a class because it's a class of drugs. And if you understand what the class does, you know a lot more than studying one drug at a time. And based on the last couple of weeks, having feedback from many students that I've been studying with in your cohort and teaching them, they have been utilizing my methods, and it's been very successful. So I highly recommend using a drug template. So just to quickly go over, here is where you would type the generic and the trade name. Generic is the actual drug's name, like metoprolol, and whatever the brand name might be. Usually that's different, like Tylenol and acetaminophen. Acetaminophen would be the generic name, and then the trade name would be Tylenol. The class, right? Like I said, you're working with medications and you're working with drug classes. So if the drug class is antihypertensive, if it's sympathetic, you should write whatever it is. The indications, that's what that drug or what that class of drugs is used for. The mechanism of action is where it works. Where it works is the receptor. So as I keep emphasizing, the receptors become very important. So if you know what the receptor does, you also know what sorts of indications or what sorts of diseases or illnesses that it's going to treat. You also know the contraindications or potential adverse effects from knowing those symptoms. So it becomes very important. And I think this is just a very clear way to write it all out. It also has nursing implications here, which is great, in patient education, which is the focus of what these professors are going to ask you. It's important to know the drugs, but you also need to know patient education and what you are going to do as a nurse. So that's why I emphasize using a drug template when writing out your classes. So I'm going to go back to share the PowerPoint and we're going to get started. So like I said, sympathetic nervous system, we're talking about stimulation of the heart rate, the blood pressure, no peeing, no pooping, and you have bronchodilation, which is a fancy way of saying that your lungs are expanding, allowing you to breathe. So we have something called the adrenergic response, which is another way of saying sympathetic response. Norepinephrine is one of those drugs that works. It's basically a fancy, it's a drug that works in the nervous system, and it works in the nerves. That's why it says sympathetic postganglionic, because there's the pre and the post. Regardless, it's just the way the drug is transmitted because it works through the nerves. And norepinephrine is one of those important drugs because they mimic the nervous system. And it's actually considered a catecholamine. And a catecholamine is a drug that has a brief action of duration. So it works very briefly and it doesn't cross into your cell membranes. So it doesn't get into the brain, which is really good. So it's not going to cause any like CNS effects. But even without knowing all of those fancy terms, norepinephrine is a sympathetic working drug. So it stimulates the sympathetic nervous system. Okay, so norepinephrine, like I said, they belong to catecholamines, and other catecholamines include dopamine, epinephrine, and isoproterenol. This is a mechanism of how norepinephrine works. It might seem very confusing, but the moral of the story is that it works in your nervous system, and when it is released, it's going to cause sympathetic response. That's your focus, okay? It's a sympathetic response. So adrenergic receptors, they have sites on the effectors, meaning where it's going to work, right? Every receptor has an effector, the organ or place that it's going to affect, that responds to epinephrine and norepinephrine, stimulated by the neurotransmitter and release of circulating norepinephrine into the bloodstream. That is norepinephrine is a neurotransmitter that gets released into the bloodstream, and that's how it works. But remember, it's sympathetic. That's a fancy way of saying a lot of these things. I know it seems much more confusing when you're hearing a bunch of terms, but just know this is sympathetic. And we're talking about alpha and beta receptors when we're talking about these drugs. Now, you would have to search these on your own because there's a lot of drugs that work on different receptors, and I don't want to overwhelm you. But if these are the drugs that your professors highlighted, which is what I'm noticing that the PowerPoints in both classes overlap, you need to know what receptors a drug works on, because as I keep mentioning, it's very important to know where the drug works. So for example, norepinephrine works on the alpha-1, alpha-2, and beta-1 receptors. Epinephrine works on alpha-1, alpha-2, beta-1, beta-2. Dopamine works on dopamine receptors, but also alpha-1 and alpha-2. And lastly, sorry. Okay. So like I said, there's different receptors, and knowing which drugs work on what receptors is really, really important. Okay. So I'm back. Sorry, I had to do something quickly. So yeah, there's different receptors, and I want you to make note of that. So what you should be writing down is what the different receptors do. So there's alpha-1, alpha-2, beta-1, beta-2. Alpha-1 and beta-1 work on the heart. So they're going to cause sympathetic stimulation in the heart. So alpha-1 causes vasoconstriction, which means that the veins or the vessels in the body start to close, which is going to cause increase in heart rate and increase in blood pressure, which is the symptoms that we mentioned before in the sympathetic nervous system. Beta 1s also work on the heart, and they cause vasoconstriction, which means squeezing of the veins or the vessels, and it also causes increased heart rate. Now, something interesting that alpha-1 does, besides working in the heart, is that it causes contraction of the bladder. In other words, it prevents the bladder from releasing the urine, so you don't pee, which is important because you're going to see in the classes of drugs that we're going to talk about soon that when they work on the alpha receptors, how this becomes important. So know that alpha-1, beta-1, they both work on the heart. They both cause vasoconstriction and increase in blood pressure, increase in heart rate. Alpha-1s contract the bladder, preventing you from peeing. Beta ones, on the other hand, increase the heart rate as well and the blood pressure, but they also increase the heart's contractility. Next, we have alpha 2. Don't really need to know much about that. There's not really many drugs, so I'm not going to really get into that one. But beta 2 works in the lungs, so it causes bronchodilation, which becomes really, really important because it helps expand the lungs, which you'll see a lot in your respiratory medications. And it also causes glyconeolysis, which means that it breaks down glycogen, which means you have an increase in sugar levels. So beta 2 works on the lungs and causes bronchodilation or expansion of the lungs to allow you to breathe, and glyconeolysis, which is the breakdown of glycogen into sugar. So that's some of the things that I want to get with the receptors. For the other thing that I want to talk about is the parasympathetic receptors, and they work on acetylcholine, which is another type of neurotransmitter. But these receptors, when you bind to acetylcholine receptor, it's going to cause parasympathetic symptoms, which is the opposite of what the alpha and betas do, and all of those symptoms that we talked about before. So we have cholinergic receptors, whereas the adrenergic receptors were the alphas and the betas. In this, we have the nicotinic and muscarinic. The nicotinic we'll get more into in a different system, but the main ones that you're going to be seeing in these classes of drugs are the muscarinic receptors, where these work in different places. They're in many of the organs, the GI, the bladder, the heart, and smooth muscles pretty much everywhere. That's where you get most of your sympathetic reflexes. That's why you get slowed heart rate, slowed blood pressure, able to pee, able to poop, because of where it's located, where these muscarinic receptors are located. And like I said, all of these are neurotransmitters, so it's just a fancy way of saying they work in the nerves and things like that. So we already talked about the different types of receptors. Now it's really important, if you're using the drug template, when you're talking about the different types of receptors, you're writing in, okay, I'm going to be working on alpha receptors if that's where the drug works. I'm going to be working on muscarinic receptors if that's where that works. That's where it becomes really, really important. So now we're going to talk about adrenergic agonists, which means that they mimic the adrenergic system, which means they mimic the sympathetic nervous system. So non-selective means that they work on pretty much most of the receptors. If it's selective to a receptor, that means it might work on alpha or it might work on beta, but these don't. So as I said before, you wrote down some of the ones, some of the receptors that these work on. Like I said, dopamine works on dopamine receptors, also works on alpha and beta. Epinephrine works on all the alphas and all the betas. And norepinephrine works on the alphas and only beta 1 receptors. So that's where that becomes really important. And ephedrine is another one, and those work on all the alphas and the betas. And for all of these, especially epinephrine, dopamine, and norepinephrine, these three, they all work to treat shock. Why? Because shock is what happens when your blood pressure drops and your body is not being perfused properly. So when you give epinephrine or dopamine or norepinephrine, it helps reverse some of those effects. But dopamine is really the drug of choice for shock because of the fact that it works on dopamine receptors, but it also works on alpha 1 and beta 1. Since it works on dopamine receptors, that means that it increases perfusion to the kidneys. And as you learned in med-surg, shock is when you lose perfusion to your organs. So if you have a receptor or a drug that works on maintaining perfusion to a vital organ like the kidneys, that's really important. So that's why we like dopamine, because it treats shock, but it helps maintain kidney perfusion because it works on dopamine receptors. So all of these drugs, like I said, can treat shock. Epinephrine is also one of those drugs that can treat another type of shock called anaphylactic shock, right? When your body gets a really bad allergic reaction and everything starts to swell up, epinephrine is really good for that. And it's used for circulatory support. Why? Because like we said, with this idea of shock, if you have lack of perfusion, you don't have really circulation. So these become very good. Adverse effects, remember, sympathetic stimulation. But the most important effects include tremors, tachycardia, cardiac arrhythmias, nausea and vomiting, and hypertension. Also anxiety, but the tremors is a really popular question that they like to ask about. Tachycardia is always one of those side effects, even disregarding just epinephrine. This class of drugs, see the word that I'm using, that works on these adrenergic receptors or these sympathetic receptors like the alphas and betas, they all cause tremors. They all cause tachycardia or increased heart rate. They all cause arrhythmias or irregular heart rate and anxiety. So that becomes really important. But tremors and tachycardia are one of the very important adverse effects that you see in these drugs, or very common, should I say. Next is you have norepinephrine. Like I said, you need to go back if you need to rewind and know where these receptors work. Remember, epinephrine before works on all of alpha and all of beta. That's why we have the increased heart rate, the increased blood pressure, the hypertension, and the adverse effects. Why we have that sweating, right? Because it's sympathetic. All of these receptors mimic the sympathetic nervous system. So if it works on alpha 1, it causes that vasoconstriction, which means increased heart rate, increased blood pressure. A lot of times where it works is also its adverse effects. So as you're seeing here, increased heart rate, increased blood pressure is what it does at those receptors. So you're literally seeing a mimicking of the symptoms that it does at the receptor. And that happens a lot. A lot of the adverse effects that you see in the medications are also the actions of where those receptors work. So it's very interesting. But think about it. If they work on alphas, and they're causing increased heart rate, increased blood pressure, that makes sense because of where it works. Also works on beta 1, which is another way of increasing your heart rate and increasing blood pressure. Because remember, those two work on the heart. And then beta 2 works in the lungs. So we're not really seeing too much beta 2 action, but still we are seeing especially those highly alpha related symptoms here in the increased heart rate, the tremors, and things like that. Similarly in norepinephrine, right? This is a vasopressor, which means that it helps opening the veins. They have little impact on beta 2s. Kind of saw that in the other one. But like I said, these work on mainly the alphas. So what sorts of indications can it do? Hypotension. Why? Because it works on alpha 1. And if it works on alpha 1, that means it causes vasoconstriction or increased heart rate, increased blood pressure. And we already talked about why it can be used for shock, because it's helping to increase that perfusion by causing those vasoconstriction and increasing that blood pressure that's low from the shock. Adverse effects might be organ damage to the bowels, livers, and kidneys, impaired circulation, and tissue necrosis. This is because if you cause vasoconstriction, there's a possibility of the vessels being closed up too much and causing a lack of blood flow. So that's why we might see that. Next, we have ephedrine, which can be used for narcolepsy, depression, appetite suppression, allergies. Ephedrine is really important where you see it in allergies and congestion. Why? Because any vasoconstrictor or anything that works on the alphas will help with removing congestion. So when you vasoconstrict, it actually alleviates some of that congestion that you get. That's why you'll see coming up some of the alpha medications that we're talking about are in your cold medications. So they work because they work on alpha receptors and they cause that vasoconstriction. Adverse effects include CNS stimulation, arrhythmias. See that pallor and tachycardia? You're going to see an increase in these sorts of symptoms. Why? Because look what it says. It works directly on alpha and beta receptors. So it causes cardiac stimulation, bronchodilation, or vasoconstriction. So because it causes that, because of the fact that it works on those alpha and beta receptors, we're going to have that pallor and we're going to have that tachycardia and we're going to have arrhythmias. The next thing is we have dopamine. Like we talked about, they work on dopamine receptors. So they help with kidney perfusion. It has those vasoconstrictive effects. It could help with shock, increase cardiac output because of those vasoconstrictive effects. But remember, it also works on dopamine receptors, which means it causes perfusion to the kidneys, which is very good in shock. That's why we do use it in treatment of shock, and it's usually the drug of choice. Adverse effects, here we go again, tachycardia, anxiety. Why? Because of where it works. And we do not want to give these drugs to someone who takes AMO inhibitors or TCAs. They're types of antidepressants, which you'll get into because they cause CNS stimulation, and that's not good. So we definitely don't want them taking that, because if you have drugs that are going to further stimulate the CNS system and these drugs are also stimulating it, it's not good. So now we have selective, so now we talked about those drugs. Now selective blockers are going to be working on these receptors but causing the opposite effects. So if I'm going to block an alpha-1 receptor, that means instead of causing vasoconstriction, I'm going to cause vasodilation. Same thing. If I'm going to have drugs work where they block the beta-1 receptors, that means they're going to block the vasoconstrictive properties or the increased contractility that we get in those. So we're going to have decreased heart rate, decreased blood pressure, because they're blocking it. They're going to cause the opposite symptoms. So now this chart, memorize it. You're going to need to know it forever, because once you know where these receptors work, if you know what they normally do, you know what happens when they block them, because they do the exact opposite. So that's where it becomes very, very important. So we already spoke about all of these symptoms. This was the chart that I spoke about before with all the symptoms that these things do. But like I said, the vasoconstrictive properties and the closure of the bladder sphincters are very important. In the alpha-1 like receptor, the beta-1s, the increased heart rate and the increased myocardial contractility are the most important ones in there. And the beta-2s, the most important thing is the bronchodilation and the glyconeolysis that you get in the beta-2s. Once you know and memorize these receptors, you know exactly what they do. So we already spoke about where they work, what they do. We don't have to re-go into this, but what I want to talk about now is the therapeutic, this is the therapeutic indications of the ones that agonize, or in other words, mimic those receptors. So those different indications, if you're putting this in your drug template, are the increased the heart rate, the increased myocardial contractility, the bronchioles dilate, things like that. All of this is all that we spoke about in terms of the signs and symptoms that you see when you administer these type of drugs and the therapeutic indications that you expect from these drugs. Nothing has changed. And anytime you see the word agonist, it just means mimic. So these drugs mimic the sympathetic nervous system, and we already went down. So all of these things that you are seeing is the signs and symptoms of the sympathetic nervous system, but they're also different. These indications are from the different receptors that it works on, the alphas and the betas. So even while you're doing this, you can start figuring out, oh, well, if my heart rate increases, which receptors are we talking about? We're talking about alpha-1, beta-1. If we're talking about myocardial contractility, we're talking about beta-1. If we're talking about the bronchioles dilating, we're talking about beta-2s and things like that. All of that will help with getting more used to the drugs and getting more familiar with them. So we have different drugs, like I said, more agonizing them, meaning they're mimicking them. Sorry, it got confusing because I was about to talk about the blockers, but I noticed your slide switched, so I'm just going to go back. We're talking about the ones that agonize, meaning they mimic. So we're still talking about all of those symptoms that we said. And I said when we get to the blockers, that means they do the opposite of those symptoms. They block them. So, but now we're not talking about that. So dobutamine, phenylephrine, clonidine, and I don't know how to say that word, but that drug. Okay, so we have dobutamine, which is a synthetic beta-1 selective agonist, which in short term means that it favors the beta-1 receptors and it works on beta-1. This is really good because this drug is very, very important in treating heart failure. It's one of our heart failure drugs. Adverse effects, hypertension. Why? Because it works on beta-1, which means it causes increased heart rate and increased blood pressure. It can cause fever, leg cramps, things like that. But an adverse effect is you're seeing is where it works directly, because it works directly on those beta-2 receptors. Now we have phenylephrine, which is a vasopressor, and it works predominantly on those alpha receptors. What does that mean? Vasoconstriction. And you're going to see phenylephrine or pseudoephedrine, those used for nasal congestion. Why? We spoke about that. The idea that the vasoconstriction helps with alleviating symptoms of congestion. Other ways that it could be used in spinal shock, sepsis, tissue shock, but the main use is this nasal congestion. And remember, we said all of this class of drugs mean the drugs that mimic the sympathetic nervous system. The adverse effects include tachycardia, tremors, arrhythmias, sweating, right? Because that's what it stimulates. Tachycardia is one of those known adverse effects, and you should know that. Clonidine is also a selective alpha adrenergic agonist, which means, in other words, it mimics the alpha receptors. Particularly, let me just double check, but it should work specifically on alpha 1 receptors. Yes, so like phenylephrine, it specifically works on alpha 1. That's why it causes that vasoconstriction. So this drug is really good because it can treat hypertension by lowering the blood pressure. Because sorry, my bad. This is actually one of those alpha 2 drugs. I apologize. So I know I said we don't really talk much about alpha 2, but this works on alpha 2 because if you go back into the signs and symptoms of the adrenergic receptors on this slide in slide 24, it inhibits norepinephrine. So if it inhibits norepinephrine, it does not allow for those sympathetic stimulation. I apologize. So I think this would be good to write alpha 2. So if it works on alpha 2, it would treat hypertension because it can lower blood pressure because it blocks norepinephrine. So it blocks that sympathetic response. I apologize if I was confusing before. But yeah, so since it works on alpha 2 and it blocks that norepinephrine, that means we're blocking sympathetic responses. So we're going to be able to treat hypertension. So this drug treats high blood pressure. Adverse effects include dizziness, sedation, dry mouth. Why? Because if it's going to block the sympathetic nervous system, we're going to have a dry mouth, right? And we're going to have sweating and things like that. And where you normally would have that sweating in the sympathetic, you're not going to really have that here. So that's why we're getting that dry mouth. And you're going to also have dizziness because it's going to be treating hypertension, which means going to be lowering the blood pressure, which causes dizziness. Okay, so then we have non-selective or selective for alpha 1s. These are different types, but these are antagonists. If they antagonize the receptors, that means that they block the effects of the alphas. So normally alpha 1 would do the vasoconstriction, and remember we also said it prevents you from peeing. Now it's going to do the opposite. It's going to cause vasodilation, and it's also going to help you pee. So like I said, antagonist means that they block those alpha receptors, which means it causes the opposite effect. They're useful in hypertension. Why? Because instead of increasing the blood pressure, now they cause vasodilation, which expands the blood vessels and lowers the blood pressure. They also are used in BPH. Why? Because benign prostate hyperplasia, that's the way of saying it, is basically the prostate gland is really enlarged and blocks some of the bladder, making it hard to pee. So these drugs actually help in peeing. And they also help with heart failure because they help reduce some of those symptoms that you get from heart failure and help with the heart. But we have phenooxybenzamine, which is a non-competitive, non-selective alpha. So it can work on alpha 1 or alpha 2. This is used for high blood pressure. Why? Because we're blocking the alpha receptor. So if we're blocking the alphas, we're going to have decreased blood pressure. It's also used in preoperative management of patients with pheocytoma, which is basically a tumor that you get that causes like sympathetic stimulation. In other words, this tumor causes increased heart rate, increased blood pressure. So because of that, we give this medication because it's going to counteract those effects by reducing the heart rate and reducing the blood pressure. So that's why it's really important, and that's why it's used to decrease blood pressure. Phenetolamine is a competitive non-selective alpha agonist. Other words, it can work on both, which means you could use it to treat blood pressure. Prazosin is very, very, very important. It's a competitive alpha 1. So it works mainly on the alpha 1s, but it blocks the alpha 1s. So it's used mainly for BPH. You could also use it for high blood pressure, but it's mainly used for BPH because of the fact that, like I said, the alpha 1s normally would contract the bladder, preventing you peeing and cause vasoconstriction. Now it causes vasodilation and helps your bladder relax in order to go to the bathroom. Other drugs in this class include tamsulosin, zosyn, doxazosine. Anything that ends in this zosyn ending lets you know that it's an, oh, that color is not good. But anything that ends in zosyn lets you know that it's an alpha blocker. So the drugs that we talked about before, like an epinephrine, norepinephrine, they don't really have an ending. So those are the drugs that you have to learn where they work. But now you're going to start getting to drugs that have an ending. So the drugs that block alpha 1s have the same ending and they end in zosyn, which becomes very important. And now the drugs that work on antagonizing these alpha receptors, or in other words, blocking them, tells us a lot about the drug. So it tells us that if they block alpha 1, that they can be used to treat hypertension and they can be used to treat BPH. So it's one of those things that becomes really important with the zosyns, but it depends on which ones we're talking about, because prazosin is more or less used for hypertension, but the other ones like terazosin, tamulose, things, they could also be used for BPH, but they all can be, because that's the fact that they do help with going to the bathroom. So I just want to keep that in mind, that these prazosin or tamulosin, terazosin, doxazosine can help with things like BPH, and they can help with treating blood pressure. They can be used in different ways because of the fact of where they work and blocking the alphas, but this one mainly is used for hypertension. So now we can go into more of the drugs that block. So the alphas, like I said, they do have an ending, and this is where you need to know which drugs work, because prazosin is the prototype drug for that class, for the blocking of the alphas, but they all have some differences. Like I said, some work on treating mainly hypertension, some can work for treating BPH, so it really depends, but they can technically be used for either because of where it works, but it's which ones are favored more. Like tamulosin is one of those drugs that can be used for BPH, as well as terazosin, which actually can be used for both. So it just really depends, and that's where you have to start figuring out which ones can be used for what, and that comes with research. But important with all of these drugs that start blocking these alpha or beta receptors like this one is that they can cause orthostatic hypotension and syncope, which basically is when you go from a lying to a sitting and standing position, your blood pressure changes. So really important nursing education for these drugs would be to give the first dose at bedtime. The first dose, so the first time they ever take this medication. This is because of the fact that they will experience something called first dose orthostatic hypotension, which means their blood pressure is going to drop really rapidly, and that can be kind of scary. So we don't want our patient at risk for falls. This is a nursing education. Also, like I said, dizziness, that's something we want to tell them that they need to watch out for, because that means their blood pressure is dropping, because remember, these block those alpha 1s, and if they block the alpha 1, that means that they're causing vasodilation instead of vasoconstriction, which means decreased heart rate, decreased blood pressure, and they could also make you pee. But nonetheless, with all of these patients, if they're taking anything that's going to reduce their blood pressure, you always want to have in your patient education to tell them to change positions slowly, and that they may experience dizziness. So we really, really want to be careful because, like I said, of that low blood pressure. Now, these are adrenergic antagonists, or drugs that block the sympathetic nervous system response acting on these beta receptors. Now, they can work on beta 1 or beta 2. Beta 1s, like I said, beta 1s affect the heart. Beta 2 affects the lungs. All of these drugs end in OLOL. So metoprolol, propranolol, esmolol, atenolol. You see the common ending? That's how you're going to be able to identify or classify these drugs. Okay, I know that these drugs work on the beta receptors, but they antagonize them. So they prevent those effects. So this is where you have to figure out where these drugs work. Is propranolol. Propranolol is actually a beta 1 and beta 2 working drug. Metoprolol is a beta 1 selective drug. So that's where you have to do your research and figure out which receptors these drugs work on. But like I said, metoprolol is a beta 1. So if it blocks the beta 1, it's going to cause decrease heart rate, decrease blood pressure. So it's used for the heart and it's used to treat high blood pressure, which makes sense, right? If this receptor is being blocked and it's going to block that increased heart rate, increased blood pressure, and cause decreased heart rate and decreased blood pressure, I could use it for my patients who have high blood pressure. I can also use it for patients who have chest pain because chest pain is sometimes caused due to poor blood flow to the heart. So if that's the cause of it and you give them a drug like metoprolol, it's going to help with increasing that perfusion, which is going to reduce the chest pain because these now vasodilate because they block those receptors. It can be used as an early intervention for a myocardial infarction for the same sort of reason. And sometimes it can be used for arrhythmias. Something to know as an adverse effect, any drug that can treat an arrhythmia or an abnormally fast heart rate can cause an arrhythmia as an adverse effect. Nursing considerations, this is really important. This is the stuff they're going to ask you with all of these betas, all of these beta blockers that end in LOL. You must always check the radial pulse before you administer. It must be in its normal 60 to 100 range. If not, we're going to hold the medication. We want to make sure, because if not, they're going to have a risk for bradycardia. Why? Because all of these drugs cause decreased heart rate, decreased blood pressure. So we don't want to give it to them if it's going to make it even worse. Another really important nursing education point about this group of drugs, class of drugs, remember, class, they all have to watch out for diabetic patients because in diabetic patients, their sugar levels can be affected because a diabetic can normally know when their sugar levels are going low, but when they take these beta blockers, they might not. It masks those hypoglycemic or low blood sugar symptoms, so we need to watch out for that. And we need to really monitor our diabetic patients and tell them that they need to take their sugars a lot. Like I said, because they're working on these beta 1s, we have to be careful for bradycardia. Remember, dizziness. Dizziness is always in all of these, whether it's an adrenergic blocker or beta blocker, anything that can treat or lower blood pressure is always going to have the symptoms of dizziness because the blood pressure might get too low and it's going to cause dizziness. It can also cause insomnia, nightmares, all of those things. But like I said, dizziness, something that we want to watch out for. We don't want to stop any medications abruptly. Patient teaching, we should tell them, like I said, don't stop it out of nowhere. They might have arrhythmias, so they need to watch out for their heart rate. They should monitor that. They should check their pulse and their blood pressure when taking medication. They should not take it if their blood pressure is low, like really low, because it's going to make it worse. Not good. Like I said, we want to tell them in our patient education teaching to change position slowly. Any of these medications that affect the blood pressure, always tell them change position slowly because of that risk of orthostatic hypotension. And we want to avoid caffeinated substances because they're like sympathetic stimulants, so it's going to cause the opposite effects. So we don't want something that's going to counteract. If I'm going to have something that's going to be lowering things, but then something that's going to be increasing it like caffeine, we don't really want that. So like I said, these are some of the things that you need to watch out for. GI upset, one of those things. Why? Because now, since it blocks those sympathetic, instead of causing your body to not really be able to go to the bathroom, it starts to allow you. Propranolol is a beta 2 antagonist. It's one of those. It works on both, but it works on both beta 1s and beta 2s. So interestingly, with our beta blockers as well, that's why it's important to know which receptor it works on. Because it blocks beta 2, instead of normally causing bronchodilation, now it's going to cause bronchospasms, which means this patient is at risk for having difficulty breathing. So we're not going to want to give this to our asthmatics or COPD patients. That doesn't make sense. Why would I want to give them a drug that's going to further exacerbate or make their breathing worse when they're already struggling? So that's an NCLEX question. Never give your beta blockers to asthmatics or COPD patients, especially if they work on those beta 2s like propranolol. But like metoprolol, it also works on beta 1. So we have to tell them the same patient educations about looking at their blood pressure, heart rate, being careful when they go from sitting and standing positions, things like that. Do not stop the medication abruptly, all of that other stuff. Okay. So this is where a lot of things start to repeat. So if you know the class of medications and you know where the receptors work, a lot of things start to repeat. So as I'm doing this, I'd be writing out my drug template, writing where it works, right? If I know where it works, I also know what it treats, right? If it can lower your blood pressure and lower your heart rate because it works on these, it could help treat hypertension. Because it helps with vasodilation or opening that, this would be good for also, like I said, maybe with patients who have increased, pain in the chest or things like that. So we just have to know where it works because it's going to help with treating the symptoms. So, but all of these beta blockers, their main use is for being an antihypertensive. So keep that in mind because you're going to see that again in your cardiac lecture. Just repeating everything. And like we said, same thing with all the beta blockers, watching out for our diabetic patients because they mask hypoglycemic effects and things like that. Now, cholinergic drugs are the opposite, right? Because these drugs, instead of normally working on the sympathetics like we've been talking about, these work on the parasympathetic system, which is very different than what we've been talking about this whole time. So cholinergic drugs mimic that sympathetic nervous system, which is the opposite, the decreased heart rate, the decreased blood pressure. And I said it also causes bronchoconstriction. So we remember SLUD, SLUDD for these drugs, like I said earlier, secretion or salivation, lacrimation, urination, defecation, digestion. That is SLUD. These block those acetylcholine receptors. The ones that we're going to be mainly talking about now are the muscarinics. Like I said, they're a little everywhere. That's why in the rest and digest, you're able to eat and pee, but we have the risk of those bronchoconstriction, decreased heart rate, and decreased blood pressure. So cholinergic antagonist, which we'll get into a little later, that means they block the parasympathetic response and they cause sympathetic response. So that's going to be a little different, but you can read over this chart on your own. But the main thing is I want to get you used to how these receptors work and how to understand drugs. So cholinergic agonist means they mimic the parasympathetic system. So we're talking about, like I said, that decreased heart rate, decreased blood pressure. And we're talking about SLUD. Remember SLUD, SLUDD, for the rest of your life. So we have direct acting and indirect acting. Those are just different ways of drugs that, different mechanisms in which they work. Like I said, if it's an inhibitor, then we have different side effects than we would if we are antagonizing it. So these are the inhibitor ones, or the ones that block, and these are the ones that work on the receptors of the muscarinic receptors that affect these cholinergic drugs. So pilocarpine is one of those drugs that actually works on the parasympathetic nervous system. And that's because it works on SLUD. So since it works using SLUD, it treats something called xerostomia. And that is because it helps with a dry mouth. It can also be used to treat glaucoma because it can decrease some of that pressure that you get in your eyes. So nursing considerations, you want to remove the contact lens before administrating. Apply light finger pressure on the lacrimal sac, which is right underneath your eyes, for about 2 minutes to minimize that systemic absorption. We don't really want that. We don't want them to really drive at night because of any sort of adverse effects they might have. But like I said, this means This type of drug works on the muscarinic, which means it works on parasympathetic, which means it stimulates the parasympathetic nervous system. So we have SLUD, SLUDD. So knowing that, you know how this works. Like I said, this can also be used, it's not here, but it could also be used to treat xerostomia because of the fact that if it causes SLUD, because it agonizes it, SLUD is being used here, which means one of the things is lacrimation and used for salvation. So it could help with the dry mouth, and it helps with the glaucoma, sorry, because of the fact that it helps with producing some of that lacrimation and things like that. So that's how you're starting to see how these drugs work. Where they work and how they work is very important. So knowing the receptor, knowing where it works is really, really important. Because remember, if it causes SLUD, it causes more of that rest and digest, which is going to help your eye muscles move and helps with vision. And this helps with your near sight. So like it helps with seeing things at a very close distance. So, and it also reduces pressure in the eye. So that's why we see this drug being used in glaucoma. Then we have cholinergic drugs. See how they're also called anti-muscarinic drugs? That's because they block those muscarinic receptors. And we also call them anti-cholinergic, or I like to call them anti-SLUD, because they prevent that salvation, lacrimation, urination, defecation, digestion that I was telling you about. So atropine is a muscarinic antagonist. So in other words, that means that this drug blocks cholinergic like responses. So that means we're going to have actually sympathetic stimulation. So it kind of causes all those sympathetic like responses. So this is actually an antidote. If someone were to have a cholinergic crisis, we would give one of these drugs. So we have to be really careful with this drug. It's a very important drug, but like I said, we want to do small doses because it causes the opposite of SLUD, right? So a lot of the things, just going back to this idea of SLUD and going back to like pilocarpine, a lot of the adverse effects too that you'll see even with other cholinergic like drugs is that you'll see like increased salivation or going to the bathroom or GI issue. That's because of the parasympathetic stimulation that it's causing. Also, just one more thing before I get back into atropine is that one of the drugs that I saw on your list was bethanchal. Now, that drug is used to treat urinary retention. Why? Because it's parasympathetic. So, since it's parasympathetic, it helps you pee, whereas sympathetic didn't. And it's also used for something called neurogenic bladder atony, which is when your bladder doesn't really work after surgery. So you give them this drug because remember, parasympathetic allows you to pee. But like I said, we're not going to really get into these ones, the neostigmines, the pheostigmines, and all of that, because those are the inhibitors and they're another class of drugs. But I want to just get you on that those are also blockers. So if they're going to do blocking, we're going to have a little bit of a different effect. So I just wanted to put that out there. But going back to this antagonist thing with the atropine, like I said, it works as a drug to help with a cholinergic crisis. So we usually will give atropine. That's the drug of choice. And we give that as if they have a cholinergic crisis or like toxicity to any of those cholinergic drugs that we were talking before, because these block the cholinergic response. Like I said, mechanism of action, it's specific anticholinergic responses. So it helps with that. It moderate doses because it causes sympathetic stimulation. So those increase heart rate, all of that stuff. We have varying doses used preoperatively to diminish secretions. Like we said, it's anti-SLUD. So if it's anti-SLUD, it's anti-lacrimation, salvation, stimulates the heart rate in conditions called bradycardia. We give this drug for bradycardia. Very, very important. Why? Because it blocks that parasympathetic response and instead causes sympathetic, which increases the heart rate. It can be also used to treat mushroom poisoning. Considerations: caution with the elderly. Elderly may be agitated may get agitated or have some sort of drowsiness. They might have heat stroke, so we want to watch these. Remember, this is anti-SLUD, so it's anti-urination, defecation, digestion, salivation. So we're going to see the adverse effects as the same things that it does. So urinary retention, abnormal heartbeat, dizziness, passing out, difficulty breathing, which is more of an adverse effect related to an overdose of this medication, but the tremors, especially because of that sympathetic stimulation. And now pheostigmine, which is one of the drugs that we saw over there, that's why I don't want to get too much into, is actually the antidote for this. So atropine is the antidote for cholinergic drugs, but pheostigmine is the antidote to reverse atropine overdose. And antidotes become very, very important. Like I said, now we want to get into our patient teaching and nursing considerations, which is the most important part of these medications. And like I said, these classes of medications, all of these things that I'm telling you about repeat, but the most important one is atropine. So we want to advise our patients to use these medications, be careful with them because of the drowsiness and the dizziness, and be aware of their level of alertness. Remember, they can cause dry mouth because of the fact that they cause decreased salivation or anti-SLUD. And the use of atropine could be used for urinary retention in males with benign prostate hyperplasia, which we saw in those alpha antagonists, because it can help with going to the bathroom. So like I said, knowing a drug and where it works is so important. Just some other things that I want to point out with these antagonists is that with these specific class of drugs, let me just get my notes because sometimes I can't find them. With this, there's certain ones that I want to highlight to you that you might need to know. So scopolamine is used as a cholinergic antagonist, or it blocks the muscarinic, which means instead of parasympathetic, causes sympathetic stimulation. It's actually used for motion sickness. Ipratropium, which you're going to see in your respiratory lecture, it's an anticholinergic drug that is used as an inhaler for asthma, right? Because if it's going to cause sympathetic stimulation now, because it's blocking the parasympathetic, we said sympathetic causes that bronchodilation, so it actually helps and prevents secretions because now it's anti-SLUD. So it's anti-salivation, so it actually helps with secretions that you might get from asthma or bronchitis. Oxybutynin, that one at the bottom is actually very important because it treats an overactive bladder, right? Because if you're going to the bathroom a lot, but you're doing anti-SLUD, which is anti-urination, this drug is actually the drug of choice for an overactive bladder. So you see now, as I keep mentioning a lot of these things, how if you know what the receptor does, you know what the drug does, and you know where it works and why it works. So those are just some important drugs that I wanted to point out too. I hope all of this made sense. You can email me, and that is my review on the adrenergic nervous system or the autonomic nervous system, the cholinergic drugs, the cholinergic antagonists, and the adrenergic antagonists. So definitely make a drug template. I think you should make them for each of one of these classes, and then list out the drugs that start to differ and see if there's any sorts of differences in what that drug might do versus the other one. But regardless, usually where it works, how it works, and those adverse effects are all the same. We also have similar nursing considerations and patient teaching, which follows in that class of medications. So that's really it.